Hello, this is Garth Fraga, and I'm going to be presenting 3 papers addressing the question as to whether or not sentinel node biopsy is a protective factor against death from melanoma or melanoma mortality. So this is an example of cutaneous melanoma, which is pigmented skin cancer produced by melanocytes, or the pigment-forming cells in the skin. And this is an example of a special stain on a lymph node that we do in this procedure called sentinel lymph node biopsy, where we try and identify microscopic tumor cells with special stains that are in the lymph node that could not be detected with usual clinical examination. So let's start by discussing the significance of the outcome, which is melanoma mortality. This is a PET scan showing extensive metastatic disease of melanoma throughout this poor man's body. So melanoma is a malignant neoplasm of melanocytes, and it accounts for 3/4 of all skin cancer deaths. And the incidence of melanoma has been rising between 3 and 7% annually for the last 3 decades. In 2017, the American Cancer Society estimates that there will be almost 90,000 new cases of melanoma, and that almost 10,000 people will die of melanoma. So this is a serious disease with potentially fatal outcomes. The exposure I'd like to discuss is sentinel lymph node biopsy. Sentinel lymph node biopsy is a technique where you inject the tumor site, which is the skin, with a radioactive tracer, which is also inked blue, and then you follow the tracer to the first lymph node that drains the tumor site, and this is what's called the sentinel lymph node. And the idea is that when melanoma metastasizes, it will go to this lymph node first, which is the sentinel lymph node. Now this identifying this lymph node has significant prognostic importance. If your sentinel lymph node biopsy is negative, you have a 90% 5-year melanoma specific survival rate. On the other hand, if your sentinel lymph node is positive for melanoma, even if it's just a few cells like that picture I showed in the beginning, your 5-year survival is only 70%. So that may not sound like a huge difference, but it is a 3-fold difference in 5-year survival. So there's general agreement that the status of your sentinel lymph node, positive or negative, has significant implications on your overall survival. But what remains debated is whether or not this technique also offers a survival advantage. I mean, for instance, is it therapeutic as well as staging? Does this offer a survival advantage to the patient by performing this procedure? So I chose 3 papers that address this question. The first and probably most significant and famous was a paper by Dr. Donald Morton at the John Wayne Cancer Center. It came out a few years ago in the New England Journal of Medicine, and this is probably the most significant paper because it's the only randomized clinical trial. The other 2 papers are retrospective cohort studies that also came out in the past few years. They involve larger numbers of patients, but they are more limited because they're both retrospective cohort studies. So in Dr. Morton's trial, initially there were 2,000 patients listed as enrolled between 1994 and 2001. They were defined by what's called a Breslow tumor thickness, which is how far the melanoma has invaded into the skin. They all had to be at least 1 millimeter or more into the skin itself, or by an anatomic level called Clark level 3 or 4. Interestingly, something happened to the 2,000 patients that were initially enrolled. Only about 1,600 made it to randomization. 1,000 were randomized to sentinel lymph node biopsy, and 661 were randomized to observation. They followed these patients over more than 10 years at 18 trial sites in 7 different countries. We'll discuss this later, but the reported outcome was melanoma-specific survival. The actual application at clinicaltrials.gov was overall survival, but they only reported melanoma-specific survival. They did have fairly rigorous follow-up standards, though the techniques that were performed for follow-up vary between trial sites. But they saw them every 3 months for 2 years, then every 4 months for 1 annually, and then every 6 months for 2 years, and then annually. And they calculated hazard ratios and Kaplan-Meier curves. These 2 papers are somewhat similar, so I'll just kind of overview them together. This was a retrospective study from patients who were treated at the Melanoma Institute of Australia in Sydney. It went over a fairly long period of time, almost 16 years. All these patients had biopsy-proven melanoma with similar characteristics to those in Dr. Morton's study. The Breslow tumor thickness, which is the most significant predictor of melanoma behavior, was more than 1 millimeter in all these patients. About equal numbers in the study had undergone sentinel lymph node biopsy or observation, about 2,900 in each arm. This study was based on SEER data from the U.S., so it was a larger patient population. It wasn't restricted to a single city in Australia. There was also a larger patient population. There were 15,000 patients. They restricted the analysis to what are called intermediate thickness melanomas, those that have a Breslow thickness between 1 and 4 millimeters. They had most of the patients were in the sentinel lymph node biopsy arm, and about 4,600 were in the observation arm. One thing to note is that the SEER registry only represents 28% of the U.S. population. So while even though this is a more generalizable data by virtue of having a larger population, it still only represents a fraction of the U.S. population. The outcome in all these studies was melanoma-specific survival. I'll get to this later, but in some ways I wish they had discussed overall survival, not melanoma-specific survival, but that was the outcome measurement that was reported. All of them reported it in the form of hazard ratios. One thing that the SEER data did, the study based on SEER data did that I thought was interesting was this just kind of reported the results based on raw data. This performed a matching analysis using something called propensity matching. So they created an artificial match cohort to compare survival in those that received sentinel node biopsy and those that received observation. So this is another advantage of this study over the Australian study. These are the results from the 3 studies, and generally they're not very impressive. They set the standard as observation in the Morton study, and they found a hazard ratio of 0.84, which implies a slight benefit to sentinel node biopsy in Morton's randomized clinical trial. However, it was not significant. You can see the confidence interval spans the number 1. Both of these retrospective cohort studies set sentinel node biopsy as the standard and gave hazard ratios for observation. In both of these studies, observation produced a hazard ratio above 1, but in the Australian study it was not significant. You can see the confidence interval includes the number 1. Whereas in the US SEER data study using the matching cohort, they did find a slight advantage for sentinel node biopsy with a hazard ratio of death from melanoma of 1.18, which was slightly above the risk of death for just a sentinel node biopsy. So this is the only study that showed an advantage for melanoma-specific survival in patients who had this procedure, the sentinel node biopsy. The other 2 studies did not show a survival advantage. Notably, Morton's study was the only randomized clinical trial, so the data in it would seem to be the most valid. Each study carries strengths and weaknesses within it. The Morton study, it's a randomized clinical trial, which is our strongest form of evidence. They used random permuted blocks to assign patients to sentinel node biopsy and observation arms, so it was a pretty scientific experiment. They have a lot of data on follow-up. It's more than 10 years now. There are some significant weaknesses to the Morton study, however. The most significant to me is selective reporting. The original clinical trials registration listed the primary study outcome as overall survival, whereas melanoma-specific survival was listed as a secondary outcome. However, in their reported results, they completely ignored overall survival and only reported melanoma-specific survival. There was a Cochrane review which managed to retrospectively calculate that overall survival based on the data within some of the supplementary tables. And what they found is if you looked at overall survival in Dr. Morton's study, the hazard ratio was only 0.98, whereas the number they reported, which was for melanoma-specific survival, was 0.84. So that makes you wonder whether or not they didn't want to bring this up, since it makes sentinel node biopsy seem even less valuable. There's also some issues with attrition or dropout bias. They never explain what happened to the 340 subjects that are simply unaccounted for. And even in the study arms, there was about 10% dropout in both arms between sentinel node biopsy patients and observation patients. Finally, this is probably less significant since the primary outcomes was death, and the primary intervention was node biopsy, both of which are very clearly defined. But this was a non-blinded study across multiple different centers, and some of them were using different detection protocols for metastatic disease. For instance, some places used ultrasound and others didn't. Now, these two retrospective cohort studies have some similar strengths and weaknesses. In both of them, there's very little evidence of misclassification bias because both the intervention, sentinel node biopsy, and the endpoint, death from melanoma, are pretty clear-cut events, and it's hard to misclassify either of those events. They both show good evidence for temporality. Sentinel node biopsy clearly preceded death in the patients that were studied. Some additional advantages of the SEER data study was it was a larger study with 15,000 subjects covering the entire USA instead of a single city in Australia, and they performed this propensity matching to reduce confounding. However, both these two studies do have some significant drawbacks. Both studies showed evidence for selection bias. Perhaps the most significant, I believe, is that some patients may be advised against sentinel node biopsy because they're thought to have be too high a medical risk for a surgical procedure. If you remove these patients, if you automatically put them in the observation arm and they're medically high risk to begin with, you're artificially influencing the results in favor of sentinel node biopsy. Additionally, they note in this study that some of their sentinel node biopsy positive subjects were excluded because they failed to have a subsequent completion lymph node dissection. This would artificially bias against observation because you're removing a subset of patients for analysis who are definitely at higher risk for a poor outcome because you know their sentinel node biopsy is positive. Confounding, there were many factors that could influence survival that were not controlled, particularly in the Australian study. There were differences in gender and thickness, for instance, or melanoma tumor thickness. One of the most significant confounders that's not addressed in either of these studies is what we call social determinants of health. There's no attempt to adjust for socioeconomic status. My suspicion is that people in lower socioeconomic status may be more likely to get observation than a surgical intervention such as sentinel node biopsy. These are the people that are more likely to have poorer outcomes. In the Australian study, almost a quarter of the subjects had rather short follow-up periods of only 18 to 20 months. And then, as we mentioned, the Australian study is limited to a very small geographic area. Likewise, the SEER data, even though it does represent 28% of the U.S. population, that means 72% of the U.S. population is not represented. So some of this data may not be generalizable. And as is the case with all three of these studies, all of them focus on melanoma-specific survival rather than overall survival, which I think would be a more meaningful measurement for the effectiveness of this technique. Hennecken criteria, if we look at chance, two of the three studies are not statistically significant, show no statistically significant advantage for sentinel node biopsy. The randomized clinical trial showed no advantage. The Australian study showed no survival advantage for this procedure. There was a very small advantage, 4% at the low end, for the SEER data study. Bias, we kind of mentioned some of these, but selection and attrition bias, possible selective reporting bias and information bias in the Morton study. In the retrospective cohort studies, selection bias may have played a significant role. Neither study did a great job of controlling for confounding, though there was this propensity matching performed in the SEER data study, which did a better job of controlling for confounding. In the randomized clinical trial, most important things were controlled for in confounding. They did not control for race or ethnicity. In my opinion, they did not control for socioeconomic status, which is probably a significant variable in survival. In the Australian study, did not control for most of the factors that could have influenced survival besides whether or not the patient had a sentinel node biopsy. This, because they used propensity matching, had a lesser degree of confounding. The strength of association in all three studies is very weak. The hazard ratios are very low or close to 1. They are biologically plausible. The idea that you pick up a cancer early before it is spread widely would seem to improve a patient's survival. So there is biologic plausibility to why doing a sentinel node biopsy might improve survival. Consistency, well, 2 of the 3 studies agreed. The 2 that agreed did not show an improvement in survival. This study, which wasn't consistent with the other 2, showed a small minor improvement in survival. All 3 clearly show temporality, because it's very clear when a patient gets a sentinel node biopsy and when they die. You could say that dose response is not applicable here, since we're looking at kind of black and white conditions, but none of them clearly address dose response. So if sentinel node biopsy is not going to improve your survival, is it a good screening test? Perhaps it does still have value as a screening test if it's not a therapeutic test. Well, these are some of the criteria we learned in our class that have defined a good screening test. Can the disease be detected early? Yes, melanoma can be detected early with sentinel node biopsy. What's the positive predictive value of a test for predicting distant mets? Well, the sentinel node biopsy is actually not very good for the PPV. It's only in the 42 to 68% range. So this would be rather poor for a screening test, in my opinion. Could you have a false positive sentinel node? Well, it wasn't originally recognized that this could happen, but now we know it does happen, particularly in children. In children, there have been large numbers of patients who have had a positive sentinel node where, in fact, their disease has never ever spread beyond the sentinel node. These patients were initially assigned as having metastatic melanoma and given complete node dissections and significant chemotherapy. So yes, particularly in children, there is an issue of false positives. Is this an economic test? No. The costs are somewhat unknown. They probably vary by state, but a rough estimate would be at least $10,000 per patient. Since only 10 to 20% of patients will be positive, that means you're looking at between $50,000 to $100,000 to identify a single positive patient. Are subjects harmed by this screening test? The answer is yes. This is a surgical procedure, and while it's a less invasive procedure than some other ones out there, these patients undergo general anesthesia. They have some disruption of their nodal drainage basin, so they are at risk for surgical complications. Do patients benefit from early detection? Well, if there's no survival advantage, it becomes very debatable whether or not patients benefit from early detection. On the one hand, there may be some benefit in the sense that you have a better idea of your prognosis. If you're sentinel node negative, it's 90% 5-year survival. If you're positive, it's 70%. There are many new therapies that are coming online right now that may work better with the disease is detected early, but we really just don't know at this stage. So is there an alternative? Well, I think there is an alternative that's come out. There's something called gene expression profiling. This is a test where you look at the genetic signature of the tumor instead of actually pulling out the sentinel node. And this has several advantages. For one, it's non-invasive. You do the test directly on the tumor, so you don't have to do a second surgery on the patient. And it's probably cheaper. You don't have to go through surgery and admit the patient to the hospital. And it's probably better. When you do this test, you break the patients into class 1 and class 2. Class 2 is a poor prognosis group, and you can see that these Kaplan-Meier curves show much greater separation between class 1 and class 2 than sentinel node biopsy negative and sentinel node biopsy positive. So even though this is a new test that needs further validation, it seems to suggest it's a better predictor of survival than the sentinel node biopsy. It is certainly much less invasive. So in conclusion, sentinel node biopsy for melanoma does not improve survival. Sentinel node biopsy for melanoma has significant limitations as a screening test. These data suggest that first, we definitely need more randomized clinical trials comparing sentinel node biopsy to gene expression profile testing in terms of managing and staging patients, and also in determining the advantages of early treatment with some new adjuvant therapies in patients who are either gene expression profile positive, i.e. class 2, or sentinel node biopsy positive. Finally, I think these data really should make us question how tests are introduced in this country. This is an invasive test that is widely practiced throughout the United States, despite the fact that the evidence in support of it seems to be rather weak. In the future, it would be nice to see higher standards of evidence prior to implementing surgical therapies and screening tests in the United States. These are my references. Thank you very much for your attention.